Hello, everyone, and welcome. Today, we're going to be focusing on Chapter 16, which is all about personality disorders. Before we can talk about personality disorders, let's first talk about personality. Personality are uniquely expressed characteristics that influence our thoughts, our behaviors, our emotions, and how we interact with individuals or lack thereof. Personality also ties into our own individual personality traits. And these are particular, predictable, and flexible characteristics that make us who we are. Some people develop a personality disorder. This is an enduring, rigid pattern of inner experience and outward behavior that leads to significant problems and psychological pain for self and others. It's important to differentiate between personality disorders and other mental health issues that we've talked about during our time together. Because with personality disorders, these don't have chemical imbalances or chemical outcomes that are associated with them. With personality disorders, these are typically learned patterns of behavior that influence an individual's behaviors, emotions, thoughts, and interactions, or lack thereof, over time. When we look at the DSM 5 in assessing and diagnosing someone with a personality disorder, there are certain things that we need to look out for. So, we need to look at what the individual is saying to us because this individual will typically display a long term, rigid, and wide ranging pattern of inner experiences and behaviors that leads to dysfunction in at least two of these four areas: cognition, which is thoughts, emotion, social interactions, and impulsivity. And typically, the individual's pattern is going to be significantly different from ones usually found in their culture. And the experiences can cause significant distress or impairment. This here is going to be key. As we're going to talk about the different clusters associated with personality disorders, there are 10 personality disorders total in the DSM 5, and they're broken down into three clusters. And as you will see, that getting someone to reflect about how this may be distressing or impairing their relationships or impairing their life is often going to be the biggest challenge. Something else to note with personality disorders is that symptoms typically last for years. And personality disorders, because of the lack of understanding and poor introspection due to impulsivity and due to the fact, as you will see, that with many of these personality disorders, these individuals don't think it's them that have the problem, it's everyone else around them. So it's among the most difficult psychological disorders to treat. It's estimated that around 15% of the US population at some point in their life will have a diagnosed personality disorder, or a diagnosable, I should say, personality disorder, whether it's diagnosed or not. And comorbidity, or having two or more diagnoses, is often extremely common. What we see here is the 19th century theory of phrenology. And when we look at phrenology, which was coined by Franz Joseph Gall, he suggested that the brain consists of distinct portions, each of which is responsible for some aspect of personality. Phrenologists tend to assess personality by feeling bumps and indentations on a person's head. We don't do that as much anymore. So the DSM 5, as I said, identifies 10 personality disorders, which are organized into three categories or clusters. When we look at these three clusters, remember that the various personality disorders will overlap with each other so much that it can actually be difficult to distinguish from one another. The frequent lack of agreement between clinicians and diagnosticians has raised concerns about the validity or accuracy and reliability or consistency of these categories. And diagnoses of these disorders can easily be overdone. So, as we are moving forward, I want us to keep in the back of our minds, why do some theorists challenge the use of DSM-5 categorical approaches to personality disorders? And which alternative approaches do they actually propose? So I know 2 slides ago we had talked about the 3 personality disorder clusters. So here is a pictorial depiction of clusters A, B, and C. I also found this table from another textbook that I think does a really great job of breaking down cluster A, B, and C. I encourage you to pause this video to take a look at this, and when you're ready, continue forward. Okay, so let's break down the clusters and let's break down the personality disorders within each cluster. The first cluster that we're going to be looking at are odd personality disorders, which includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. So people with these disorders display behavior similar to, but not as extensive as schizophrenia. And when we look at these behaviors, they're going to include things like extreme suspiciousness, social withdrawal, and peculiar ways of thinking and perceiving things. These behaviors typically leave the person isolated. Some clinicians believe that these disorders are actually related to schizophrenia, so they call them schizophrenia spectrum disorders. Clinicians have learned a lot about the symptoms of odd personality disorders, but little about their causes or how to even treat them. And part of the reason is that there's very few people with these disorders who actually seek treatment. So treatment success is limited. Let's first look at paranoid personality disorder. And this is characterized by deep distrust and suspicion of others. So these individuals will typically have very limited close relationships, and they're often seen as being cold and distant in their affect. They have excessive trust in their own ideas and abilities, and are often hypercritical of weaknesses and faults in others. It's estimated that it's experienced by about 4.4% of US adults, and it's more common in men than women. So, whom do you distrust? When we think about distrust and the suspiciousness, these are the hallmarks of paranoid personality disorder. Even in people without this disorder can often be distrusting. So what you see here in figure 16.1 are the percentage who distrust um, those with paranoid personality disorder. Who do they actually distrust? Well, the information from the internet is going to be the biggest factor, which is 98%, followed by mass media at 68%. And then you see the people that they distrust going downward. I encourage you to take a look at this chart because this is going to be important in how we are working with someone who potentially has paranoid personality disorder and who they distrust. So when you look at various surveys, which is where this information came from, the majority of respondents said that they do distrust the internet, mass media, and Congress, which is something that has been long-standing where these individuals distrust those in these groups of people or these groups of information. And when you look at how this information was generated, we're going back 9 years worth of polls. So when we are looking at the theoretical explanations, the psychodynamic perspective would say that this is linked to patterns of early interactions with demanding parents. So essentially, these individuals were typically demanded and smothered, or were placed into demanding situations and smothered by their parents, which have led them to be distrusting of the world around them. The cognitive behavioral approach would say that this is tied to broad maladaptive assumptions of others. The biological approach would say that there are potential genetic causes. And something to think about is that when we look at this biological approach, biological theorists propose that these genetic causes are what lead people to develop paranoid personality disorder, and they've looked at twin studies to support this. People with paranoid personality disorder don't typically see themselves as needing help. So it's hard for us to get a lot of theoretical explanations behind it. Remember that these explanations are proposed. And like most of the other personality disorders, they have been the subject of very little systematic research. So keep that in mind. Also, when we again look at treatments, they don't typically see themselves as needing help. So few will actually come to treatment willingly. Those who are in treatment will often distrust and rebel against their therapist. And as a result, therapy for this disorder, as for most of the other personality disorders, has limited effectiveness and typically moves very slowly. So when we look at the psychodynamic perspective, we look at object relations therapists. Object relations therapists try to see past the patient's anger and work on the underlying wish for satisfying relationships. So many of the individuals with paranoid personality disorder, they will often seek self-therapists, and self-therapists will help them to attune in more to themselves and then tie that back into the relationships with others. From the behavioral perspective and also the cognitive perspective, these therapists try to help clients control anxiety and improve interpersonal skills. So cognitive therapists, they typically try to restructure the client's maladaptive assumptions and their interpretations. When we look at biological, drug therapy is of limited help because in many cases, if it is not comorbid with another mental health diagnosis or another mental illness or psychological disorder, it's behaviorally based, not chemically based. So providing drug therapy, which has the ability to modify the chemicals in one's brain and body, by giving someone drug therapy where this is a behavioral issue, you're going to find that the outcomes are going to be more limited. Now let's look at schizoid personality disorder. And this is characterized by persistent avoidance of social relationships, and they have very little demonstration of emotions. So these individuals typically focus primarily on themselves, and they're generally unaffected by praise or criticism. They tend to be very much indifferent. Their preference is to being alone. Therefore, they lack social skills. And the lack of intimacy is actually of interest because those with schizoid personality disorders tend to have significant marital or family problems. It's estimated that about 3.1% of US adults have schizoid personality disorder annually, and it's slightly more common in men than women. So people with schizoid personality disorder focus mainly on themselves and are often seen as flat, cold, humorless, and dull. And when we look at the disorder, it's something from a theoretical perspective. And in looking at these, remember that it is limited in systematic research. Many psychodynamic theorists, particularly object relations theorists, link schizoid personality disorder to an unsatisfied need for human contact. The parents of those with this disorder are believed to have been unaccepting or potentially abusive of their children. Cognitive theorists propose that people with schizoid personality disorder suffer from deficiencies in their thinking. Their thoughts tend to be vague and empty, and they have trouble scanning the environment for accurate perceptions. Their extreme social withdrawal prevents most people with schizoid personality disorder from entering therapy unless some other disorder makes treatment necessary. And even then, patients are likely to remain emotionally distant from the therapist, seem not to care about treatment, and make limited progress. When we look at cognitive behavioral therapists, they sometimes have been able to help people with this disorder experience more positive emotions and more satisfying social relationships. The cognitive therapist piece, or the cognitive therapy aspect, will focus on thinking about emotions. The behavioral aspect will focus on the teaching of social skills. Group therapy is apparently useful as it offers a safe environment for social contact. And again, going back to that biological piece, drug therapy is of little benefit because, again, this is behaviorally based, not chemically based. Finally, we have schizotypal personality disorder, which is the last personality disorder, I should say, of cluster A. So personality disorders, schizotypal personality disorders, often characterized by a range of interpersonal problems and is marked by extreme discomfort in close relationships, often odd, even bizarre ways of thinking, and behavioral eccentricities. So these individuals believe unrelated events pertain to them in important ways. For example, someone with schizotypal personality disorder might believe that when there is an event that happens that garners national attention, that this is the, someone's way of communicating to them. May it be the government, or may it be the individual who is, talking on the TV, that they are communicating exclusively to them. They often will have bodily illusions as well. Bodily illusions meaning that they think that they are bigger than what they are, or that they are smaller than what they are. They often demonstrate difficulty keeping their attention focused. They have a very hard time staying on track and on target. And their conversation is typically going to digress and be vague, even sprinkled with some loose associations. It's estimated that approximately 3.9% of adults have or would be diagnosable as having schizotypal personality disorder. And like the other two personality disorders in cluster A, it's slightly more prevalent in males than females. Because the symptoms of schizotypal personality disorder so often resemble those of schizophrenia, researchers have hypothesized that similar factors are at work in both disorders. Schizotypal symptoms are often linked to family conflicts and to psychological disorders in parents. Researchers have also begun to link schizotypal personality disorder to some of the same biological factors found in schizophrenia, such as high dopamine activity. Out of all of the cluster disorders, this one has the highest ability to benefit from drug therapy, because most often you will find that there is a comorbid diagnosis that is associated with this. Something else to think about too is that when we look at the theoretical explanations, that there's also links to mood disorders, especially depression, that have been found. So the comorbidity factor and the use of drug therapy, again, is highly evident and beneficial, or has more benefit than other personality disorders overall. Treatment is as difficult in cases of schizotypal personality disorder as it is in many cases of paranoid and schizoid personality disorders. Typically, the individual will come in for the other comorbid diagnosis or diagnoses, not necessarily for having schizotypal personality disorder. Most therapists agree on the need to help clients reconnect and recognize the limits of their thinking and powers. Cognitive behavioral therapists try to teach clients to objectively evaluate their thoughts and perceptions and provide speech lessons and social skills training. Antipsychotic drugs appear to be somewhat helpful in reducing certain thought problems. Again, because for schizotypal personality disorder, there is often a chemical imbalance that is associated with another comorbid diagnosis or other diagnoses. Therefore, the use of drug therapy can be helpful. Your book talks about mass murders. So where do these violent acts come from? Theorists have suggested a number of factors to help explain pseudo-commando, autogenic, and other mass killings, including the availability of guns, bullying behavior, substance abuse, the proliferation of violent media and video games, dysfunctional homes, and contagion effects. They also have tied into this such things as certain personality disorders like antisocial personality disorder, borderline personality disorder, paranoid personality disorder, or schizotypal personality disorder. They also have found that for many of those who commit acts of mass murders, that they may have undiagnosed schizophrenia or even severe bipolar disorder and possibly undiagnosed aspects of this. Or if they are diagnosed, then they may not be medication compliant. There's also research that shows that intermittent explosive disorder, which is an impulse control disorder, which features repeated and unprovoked verbal and or behavioral outbursts, can also be associated when the person is a minor. So if there are a minor committing acts, or if there are adults who are committing these acts, that at some point in their childhood, typically in adolescence or in their teen years, that they have displayed what would be diagnosable under intermittent explosive disorder. And finally, for some mass murderers, it could be severe depression, stress, or even anxiety. So now let's talk about cluster B. These are the dramatic personality disorders. And these this cluster of dramatic personality disorders includes antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. These personality disorders are more commonly diagnosed than others. And antisocial and borderline personality disorders have received a lot of systematic research. But what makes them dramatic is because they are emotional or have erotic problems, making it almost impossible to establish and maintain relationships. And because things like histrionic and narcissistic personality are not well understood, treatments are ineffective to moderately effective. And again, the big difference is going to be antisocial and borderline personality disorders. So let's start with antisocial personality disorder. These individuals can also be known as psychopaths or sociopaths. And these individuals they persistently disregard and violate others' rights. This individual has to be at least 18 years of age in order to receive this diagnosis under the DSM-5. And they will do things like lie repeatedly and be reckless and extremely impulsive. They have little regard for others and can be cruel, sadistic, aggressive, and violent, not only to other people, but also to property and animals. These individuals tend to have a higher rate of alcoholism, substance use disorders, or childhood conduct disorders, as well as ADHD. And aside from substance related disorders, this is the disorder most linked to adult criminal behavior. Most people with an antisocial personality disorder displayed some patterns of misbehavior before they were 15 years old. Antisocial personality disorder is estimated to be found in about 3.6% of US adults, and it's often 4 times more common in men than women. So, what are some of the theoretical explanations? Individuals with this disorder display deficient functioning in their prefrontal cortex and anterior cingulate cortex. Among other things, these brain structures help people plan and execute realistic strategies and develop personal characteristics like sympathy, judgment, and empathy. These are all qualities that lack in people with antisocial personality disorder. Similar research has found deficient functioning in the amygdala, hippocampus, and temporal cortex of people with this disorder. And these are brain structure problems that may contribute to these individual inabilities to follow the rules. Antisocial personality disorder is ultimately related to poor functioning of a brain circuit consisting of the prefrontal cortex, anterior cingulate cortex, amygdala, hippocampus, and temporal cortex, among other structures. Poor communication, that is, poor interconnectivity, between the structures in this circuit may produce chronic low reaction to stress by the two brain body stress pathways. That's the sympathetic nervous system pathway and the hypothalamic pituitary adrenal pathway, which in turn leads to a state of low arousal, weak stress reactions, poor empathy for the pain of others, and other features of antisocial personality disorder. Although enthusiasm for this circuit-centered explanation is growing, research regarding its specifics and merits is limited to the date of this video. We need to understand that in order to look at other theoretical explanations and treatment. So, psychodynamic theorists believe that there was an absence of parental love, or during their first 18 months of life, during Erickson's first stage of psychosocial development, that they did not have their basic needs met. So, there is a lack of basic trust. And antisocial personality disorder research tends to link childhood stress to their behaviors as a teen and adult. When you look at the cognitive behavioral pieces, they look at the difficulty in recognizing other people's viewpoints or feelings, which is that cognitive piece. And behaviorally, they look at symptoms that are learned through operant conditioning, modeling, and imitation, where people are able to engage in violence and have very little ramifications or negative outcomes or consequences. And again, we just talked about that biological piece, which is so important because when you have the sympathetic nervous system pathway and the hypothalamic pituitary adrenal pathway that is not functioning or not interconnecting effectively, then that can not only lead to issues within the brain and the brain body reactions, but it also can do things like lower serotonin. So, for treatment, you typically find with antisocial personality that education, especially psychoeducation, is going to be important, as is doing things like social skills training and learning new ways of establishing and maintaining healthy relationships. There's also the therapeutic community that, as part of the therapy, that there needs to be almost like immersion therapy where you have someone who's with you live and in real time walking you through how to engage with others. There's also some psychotropic medication, especially if it's related to a serotonin related issue, that can be helpful for those who have antisocial personality disorders. But it's typically going to be ineffective due to the lack of conscience and a desire to change. They typically don't think that there's anything wrong with them and that it's everyone else's problem. Now we look at borderline personality disorder. There's a number of psychopaths and sociopaths who also have BPD. And this is characterized by instability, including major shifts in mood, unstable self image, and high impulsivity. They typically have unstable interpersonal relationships and are prone to bouts of anger, which sometimes can result in physical aggression and violence. They may also direct impulsive anger inwards and harm themselves. Many of the patients who come to mental health emergency rooms are individuals with borderline personality disorder who have intentionally hurt themselves. Their impulsive self destructive behavior can include alcohol abuse or substance abuse, reckless behavior, including driving and unsafe sex, self injurious or self mutilation behavior, and suicidal actions and threats. Given the chaotic, unstable relationship characteristics of borderline personality disorder, it's not surprising that the disorder tends to interfere with job performance even more than most other personality disorders do. It's also estimated that about 5.9% of US adults meet the diagnostic criteria of being diagnosed with borderline personality disorder, and 75%, estimated 75% of individuals with borderline personality disorder are women. So let's talk about the theoretical explanations. Because of fear of abandonment, this tortures so many people with borderline personality disorder. Psychodynamic theorists look to early parental relationships to explain this disorder. Object relations theorists propose a lack of early acceptance or abuse or even neglect by parents. Research has found some support for this, including a link to early childhood sexual abuse. Some features of this disorder um, have also been linked to biological abnormalities, such as an overly reactive amygdala and an underactive prefrontal cortex. In some patients, who especially are particularly impulsive, they may have lower brain serotonin activity. Close relatives of those with borderline personality disorder are 5 times more likely than the general population to be diagnosed with borderline personality disorder. A number of theorists currently use a biosocial theory, stating that the disorder results from a combination of internal and external forces. Some sociocultural theorists suggest that the cases of borderline personality disorder are particularly linked to emerging cultures that change rapidly. What are some integrative explanations? Just talked about the biosocial one. When we also look at developmental psychopathology, they look at how childhood traumas, especially childhood sexual abuse, and dysfunctional parental attachments lead to flawed capacity for healthy relationships. So these might be where the parents were very smothering and then they were absent. And then they were heavily involved, or one parent was overtly heavily involved, and then the other parent was missing from the picture. There are positive factors that can counter these things. So they may have had one parent who was healthy, but the other parent may not have been healthy. Therefore, the learned behavior from the positive parent can be helpful, but unfortunately the learned behaviors and the reaction to the stress from that parent who may have been engaging in things like child sexual abuse or neglect, or who was overly abusive verbally or even mentally, unfortunately takes over more than the healthy parent does. When we look at treatments, the number one treatment to use for for borderline personality disorder is going to be dialectical behavioral therapy, or DBT. DBT was established by Marsha Linehan specifically to work with those who have borderline personality disorders. It is a combination of cognitive behavioral therapy and mindfulness, as well as other therapies, in order to help individuals with borderline personality to understand things like managing their distress and increasing their distress tolerance, social skills, communication skills, and using group therapy, individual therapy, and a coaching helpline in order to work through issues and problems in real time. There's also some biological treatments that have been helpful, but don't have as much efficacy as DBT. And that's using antidepressants, antibipolar, anti anxiety, or antipsychotic drugs as adjuncts to psychotherapy. And typically, if medication is going to be dispensed or administered, it's going to be for two reasons. One, because there's another comorbid condition and that is chemically based. And two, that they're going to use this in the short term to help the individual as they are coping through learning new skills and new techniques to help manage their reactions to stressors, which can cause them to essentially explode and become violent and aggressive verbally and physically towards themselves and others. Now we'll talk about histrionic personality disorder. Histrionic personality disorder is where these individuals tend to be extremely emotional and continually seek to be the center of attention. So they will engage in attention seeking behaviors because they believe they are always on stage. The center of what it is they're trying to do is to seek approval and praise from others. These individuals are extremely vain. They're very self centered and they're often demanding of other people, not only of their attention, but of their time and of comments and praise. So they seek physical, verbal, and emotional support to a degree that can be draining to those around them. Some of these individuals may make suicide attempts, but it's often to manipulate others to give them attention. For these individuals who have histrionic personality disorder, even negative attention is still attention, and they want to be the center of attention. They want to be the center of your world. The sun and the moon will rise and set respectively around them. It is typically found in about 3.6% of US adults, at least the symptomology, and it's 4 times more common in men than women. So, what are some theoretical perspectives? So, understand that they have a deep seated fear of loss. So, in order to defend against this, these individuals have learned to behave dramatically and inventing crises that will require people to act protectively against them. So, from a psychodynamic perspective, they look at individuals with histrionic personality disorder symptoms. They look at these unhealthy relationships with cold, controlling parents in childhood and feelings of being unloved or uncared for, or feelings of abandonment that stem back to their childhood. And that they looked at these real or perceived dramatic crises that were either present or invented for protection, and then emulate that as teens and adults. From a cognitive behavioral standpoint, they lack substance and extreme suggestibility that's tied to self focused and emotional behavior. And they search out others to meet their needs that are related to a sense of helplessness. From a sociocultural or multicultural perspective, there's a partial influence by cultural norms and expectations. So, how do we treat someone with histrionic personality disorder? Cognitive therapists will look at the lack of substance and extreme suggestibility found in people with the disorder. Some propose that people with histrionic personality disorder hold general assumptions that they are helpless to care for themselves. So they seek out others who will meet their needs and take care of them. When we look at sociocultural and multicultural theorists, they believe that the disorder is caused in part by society's norms and expectations. What we see is that histrionic personality disorder is diagnosed more often in Hispanic or Latino, Latina, Latinx Americans, and more often within individuals who come from an Asian culture. The vain, dramatic, and selfish behavior may be an exaggeration of femininity as our culture once defined it. Remember, though, that each approach is useful, though some may be less useful depending on the individual who's presented before you with the symptomology. The last cluster in cluster B, the dramatic personality disorders, is narcissistic personality disorder. People with narcissistic personality disorder are generally grandiose, need much admiration, and feel no empathy with others. They will often exaggerate their achievements and talents to the point of being arrogant. They are very selective about their friends, and they often present with very favorable first impressions. Some will make suicide attempts, but like with histrionic personality disorder, it's often to manipulate others. And it's common among normal teenagers and does not usually lead to adult narcissism. So when we look at narcissistic personality disorder in adults, you can often find a connection to being stuck at some point in their teens. It's typically found in about the symptomology, I should say, is found in about 6.2% of US adults, and it affects up to 75% of men. So it's more prevalent in men than women. So, when looking at the theoretical perspectives, psychodynamic theorists will typically focus on cold rejecting parents. In support of psychodynamic theory, research has found increased risk for developing narcissistic personality disorder among abused children and those who lost parents through adoption, divorce, or death. Object relations therapists will focus on grandiose self presentation, and that they will look at self sufficiency as a major factor, that they are independent, that they can do everything on their own, which replaces warm relationships with others. Cognitive behavioral theorists and therapists propose that narcissistic personality disorder may develop when people are treated too positively rather than too negatively in early life. Therefore, the individual overvalues their self worth. Sociocultural theorists see a link between narcissistic personality disorders and eras of narcissism within society. And it will be interesting to see looking back, in 50 years, when we look back at today and what has happened over the next 50 years, Is there going to be an increase in narcissistic personality disorder due to things like both parents having to work, or one parent being absent and one parent being unavailable, and the need for self sufficiency, and how that may impact how people will display or be diagnosed with narcissistic personality disorder traits? In addition, with things like social media and the ever growing need for other individuals to essentially, I'm trying to think of how to word it, from the use of social media, where people are posting information about themselves and they're posting information about their relationships. There's been some studies that are recently completed or in the process of being completed to see how those with narcissistic personality disorder view others that they see on social media who have the quote unquote healthy typical families or quote unquote healthy relationships, and levels of jealousy or over comparison that could in fact influence how they react to others. So, how do we treat narcissistic personality disorder? This is one of the most difficult personality disorders to treat. Why? Because someone with narcissistic personality disorder doesn't think there's anything wrong with them. Typically, individuals will consult therapists because of a related disorder, most commonly depression. Individuals may even try to manipulate therapists to support their sense of superiority. And when therapists don't feed into it, there could be a love-hate relationship that develops within the therapeutic relationship. So one day you may seem to have rapport, and the next session you may find that the client cancels or becomes very upset or distressed with the therapist because they don't feed into their viewpoint. Psychodynamic therapists will recognize and work through basic insecurities and the defenses that have been developed. Cognitive behavioral therapists will focus on self centered thinking and redirecting this self centered thinking, which then can lead to a shift in behaviors. Unfortunately, with narcissistic personality disorder, there's no major treatment approach that has had much success. Again, because those with narcissistic personality disorder do not believe that there is anything wrong with them, that there is something wrong with others, that they are fine, that they are self sufficient. They can do anything and everything they want. And if you don't agree with them, because they're so selective in who they keep in their world, they will bring you in. And as soon as you disagree with them, they will push you away. So let's look at selfies. Is it narcissistic or not? So there's a growing trend of individuals where they are seeking validation online through social media to engage in taking selfies. But are these helpful or are they harmful? Some people will look at the overuse of selfies in order to get likes as a form of narcissism. But also, for others, it could be part of histrionic personality disorder in receiving that attention from others. And when they don't receive it, they may then become manipulative. So, when we are looking at this, psychologist Turkle suggests that people who post an endless stream of selfies are often self seeking in their validation of their self worth, even if that pursuit may not rise to a level of clinical narcissism. There could be narcissistic tendencies or even histrionic tendencies. Other psychologists believe that, for the most part, selfies are an inevitable byproduct of technology enabled self expression, especially through social media. What are your thoughts on this? I want you to think about this. And I want you to essentially think about what is helpful about posting selfies and what can be harmful about posting selfies. And now we will go to cluster C, which are our anxious personality disorders. And these personality disorders include avoidant personality disorder, dependent personality disorder, and obsessive compulsive disorder. People with these disorders typically display anxious and fearful behavior. And with most of the personality disorder, research is limited because treatments for this cluster appear to be moderately helpful at best. which is considerably better than the outcomes with other personality disorders. So, the first of the cluster C disorders is avoidant personality disorder. And this is characterized by consistent discomfort and restraint in social situations. Also, overwhelming feelings of inadequacy and extreme sensitivity to negative evaluations from others. So, those who have avoidant personality disorder can also have social avoidant personality disorder, which is where they fear close social relationships. They may also have social anxiety disorder, which is fear of social circumstances. These two disorders may reflect the core psychopathology of avoidant personality disorder and essentially should be combined. It's estimated that about 2% of US adults have avoidant personality disorder symptomology, and it's pretty evenly split between men and women. So, what are the theoretical perspectives? So, theorists often assume that avoidant personality disorder has the same causes as anxiety disorder, even though there's no clear research ties to putting them together. But they do have some shared causes, which is early trauma, conditioned fears, upsetting beliefs, and biochemical abnormalities. Most theorists agree that these deficits first develop as a result of the individuals avoiding so many social situations. So, psychodynamic theorists will focus on shame and insecurity that's traced to childhood experiences. Cognitive theorists believe that harsh criticism and rejection in early childhood may lead people to assume that their environment will always judge them negatively. In several studies, individuals reported memories that supported both the psychodynamic and cognitive theorists, or theories, I should say. Behavioral theorists suggest that people with avoidant personality disorder typically fail to develop normal social skills or healthy social skills. So, how do we treat them? Well, when we look at how people come to us in their presentation with avoidant personality disorder, they are typically coming for another comorbid diagnosis, again, most commonly anxiety. But they often seek acceptance and affection from their therapist. The therapist will gain the individual's trust and tend to treat the disorder in the same way as social phobia and anxiety. Cognitive behavioral therapists usually suggest group therapy. This provides practice in social interactions in a safe and meaningful way. Anti anxiety and antidepressant medications are sometimes useful, but unfortunately, if they're not medication compliant, the symptoms can return. Then we have dependent personality disorder. And this is where individuals have a pervasive and excessive need to be cared for. These individuals are typically going to be very clingy and obedient, and they fear separation from their loved ones. When they're not with their loved ones, they can be distressed, lonely, sad, and not like themselves. They have reliance on others. So the smallest decision cannot be made, even going down to what do you want to do tonight or what do you want to eat for dinner? They are so dependent on the other person that they leave every decision to that other individual. They also have difficulty with separation. This is a central feature. Even doing something as meaningful as going to work, which is something that occurs with many of us day to day, separating themselves from going to work is problematic for someone who has dependent personality disorder. And especially as of the time of this video, as we are preparing to start returning to work after the pandemic, that you're finding that a lot of people with dependent personality disorder are becoming even more distressed or may have experienced distress during the day when they and their partners or loved ones were working from home. Even being separated by a room so that both of them can work was distressing. It is estimated that less than 1% of the population has symptomology of dependent personality disorder, and it's pretty split. It's evenly split between males and females. So, what are the theoretical perspectives? So, from a psychodynamic perspective, they look at this very similarly as they would depression. So, Freudian therapists and theorists would say that there's unresolved conflicts during the oral stage from birth to 18 months, that They didn't have their basic needs met, that they were hungry or thirsty, and that they did not receive the love and attention from parents. So you need to go back to that time period to resolve those issues and then move forward. Object relation theorists say that early parental loss due to death, divorce, or separation or rejection from parents prevents normal attachment and separation. Other psychodynamic theorists will say that there was over involvement or overprotection by parents. So, and that occurred for so long that as the individual went to become more independent and display um, their independence or their autonomy, that it was problematic because they still continue to have their parent or parents or primary caregiver or caregivers be so over involved and overprotected that they didn't have an ability to do so. So when something like death, divorce, or separation happens, and they're now thrusted into having to establish or maintain their autonomy without the overprotection or the over involvement of their primary caregiver, that it causes them significant distress because every decision was made for them through an extended period of time, well beyond what should have been. So now, therefore, they don't have the ability or the desire to establish and maintain their autonomy. Behavioral theorists will look at unintentional clinging and loyal behavior rewarded by dependent parents. Cognitive theorists will look at maladaptive behaviors that developed, that for many of these individuals, they felt inadequate and helpless to deal with the world because of potential overinvolvement or overdependence to primary caregivers or parents. Therefore, they now need to find a person who will provide them with the protection that they need. So, how do we treat someone with dependent personality disorder? In therapy, all responsibility for treatment and well being is typically placed on the clinician. And the key overall is to help individuals accept responsibility for themselves. So, from a psychodynamic perspective, these therapists will use transference of dependency of needs as the highlight of their therapy sessions. Cognitive behavioral therapists will often combine interventions because they want to challenge and change these notions of being unable, incompetent, and helpless to now being able to do things and have autonomy and know that they are not helpless in their situations, that in fact, they can be helpful to themselves and others. Behaviorally, they will look at assertiveness training in order to cope with these changes that are occurring. Biologically, there are some who will use antidepressant drugs when the disorder is comorbid with depression. And finally, group therapy. So, couples group therapy or family therapy can be helpful, and often a combination of group therapy, couples therapy, family therapy, and individual therapy, and some combination will be promoted. Individual therapy to work through the individual circumstances, group therapy to work on things like assertiveness, training skills in a safe place with others who may have similar concerns. And then couples or family therapy in the event that there are with a family member or a loved one, whether that be a romantic partner or parent or sibling who is enabling this codependency to continue on. Finally, we have obsessive compulsive personality disorder. In obsessive compulsive personality disorder, this is characterized by intense focus on orderliness, perfectionism, and control, and the resulting loss of flexibility, openness, and efficiency that happens is extremely distressing. Those with obsessive compulsive personality disorder have unreasonably high standards for self and others and fear any mistake. Therefore, they may be afraid to make decisions or they will do things to people please. They have a tendency to be rigid and stubborn unless they are fearing a mistake. So they will isolate or withdraw themselves, or they will engage in people pleasing, but 90% of the time they're rigid and stubborn. Those with obsessive compulsive personality disorder also have difficulty expressing affection, and relationships are often very stiff and superficial. Many clinicians believe that obsessive compulsive personality disorder and obsessive compulsive disorder are closely related. The two disorders share a number of features, and many people who suffer from one of the disorders meet the diagnostic criteria for the other. However, it's worth noting that people with the personality disorder are more likely to suffer from either major depressive disorder, an anxiety disorder, or a substance use disorder as a comorbid disorder than from obsessive compulsive disorder. It's estimated that as many as 7.9% of US adults display symptomology of obsessive compulsive personality disorder, and men are twice as likely as women to develop obsessive compulsive personality disorder. So, what are some of the theoretical perspectives? According to Freud, toilet training often produces rage in a child. If parents are too harsh in their approach, the child may become fixated at the anal stage and prone to obsessive compulsive functioning later in life. Explanations of obsessive compulsive personality disorder borrow heavily from those of obsessive compulsive anxiety disorder, despite doubts concerning the links between the two. Psychodynamic explanations that can dominate the research is often limited. So, how do we treat someone with obsessive compulsive personality disorder? So, they usually don't believe that there's anything wrong with them, very much like those who have narcissistic personality disorders. They are unlikely to seek treatment unless they are suffering from another comorbid disorder, most frequently anxiety or depression. These individuals often respond well to psychodynamic or cognitive therapy, even though the research is limited. And a number of clinicians report success with SSRIs or selective serotonin reuptake inhibitors. Again, it's primarily tied to the comorbid disorder that has the chemical basis, whereas obsessive compulsive personality disorder is predominantly behavioral. So, when we look at the multicultural factors, this research is neglected. So, in looking at the DSM 5, there's a pattern diagnosed as a personality disorder. It must deviate markedly from the expectations of a person's culture. But there's a lack of multicultural research in concern with all personality disorders, but most specifically, borderline personality disorder. So, while we have suspicions, these suspicions are assumptions, and those assumptions is pseudoscience. It's not marked with evidential research. So it's hard to it's hard to know that there are cultural differences that exist when we don't have the research to back it up. And these differences are important to the field's understanding and treatment of personality disorders. So, are there better ways that we can classify personality disorders? So, there are significant problems that have been presented by the DSM 5's current categorical approach. And some people, some researchers believe that personality disorders should be described and classified by a dimensional approach. So, these disorders should be classified by the severity of key personality traits or dimensions rather than the presence or absence of specific traits. In such approaches, the key trait, for example, disagreeableness, dishonesty, or self absorption, would be seen as varying along a continuum in which there is no clear boundary between normal and abnormal, and that people with a personality disorder would be those who display extreme degrees of several of these key traits, degrees not commonly found within the general population. They also recognize that we should shift away from the cluster approach and look towards the big five theory of personality. So, this is known as the ocean model. And it is something that is suggested for grouping, also known as taxonomy, for personality traits. It was developed in the 80s, and it essentially looks at your personality as being related to openness, conscientiousness, extroversion, agreeableness, and neuroticism. And those things create the acronym OCEAN. And that when you look at personality traits, you want to see if someone is open to experience. This is someone who may be inventive or curious versus consistent and cautious. Are they conscientious? Are they efficient and organized, or are they extravagant and careless? They look at extroversion. Are they outgoing and energetic, or, introverted and reserved? What is their level of agreeableness? Are they friendly and compassionate, or are they critical and rational? And finally, their level of neuroticism. Are they sensitive and nervous, or are they resilient and confident? And that by looking at the big five theory of personality rather than by clusters, or by looking at the big five theory of personality in conjunction with the clusters, this can help not only with psychoeducation for therapists and clients, but it can also help by looking at the ocean perspective as part of that big five theory of personality to be able to identify these clustered symptoms and to differentiate these personality disorders from other comorbid issues and diagnoses. So, again, this is just a little bit of the big five theory of personality and personality disorders. Many proponents of the five factor model argue that it would be best to describe all people with personality disorders as being high, low, or in between on the five super traits. And again, at first, we can use it to help with identifying the clusters, but ultimately dropping the personality disorder clusters altogether to look at the continuum that can happen with ocean. Again, that's openness, conscientiousness, extroversion, agreeableness, and neuroticism. When you look at the dimensional approach and using the big five theories, there is a categorical approach with assumptions, that the assumptions are that there's problematic personality traits and they're either present or absent. When you have absolute thinking and you don't look at things on a continuum, you may lose out on being able to treat someone effectively or diagnose someone accurately because they may not have the presence of symptoms, but or in the time frame in which the symptoms are present, rather than it looks like it's either here or not. And if it is here, then you have it, and if it's not here, then you don't have it. But someone may still have that personality disorder because they exhibit other traits of that personality disorder. So they look at, again, this absolute all or nothing thinking. It's either the personality traits are present or they're not. It's either the personality disorder is displayed or it's not. And a person who is impacted from a personality disorder is not markedly troubled by personality traits outside of that disorder, but that doesn't mean that it doesn't impact those around them. So when we look at it from a trait perspective, the DSM-5 framers designed this alternative dimensional approach for possible use in a future revision, so that people whose traits significantly impair their functioning should receive a diagnosis of a personality disorder trait that is specified or not. That would be labeled as personality disorder traits specified, or PDTS. When assigning this diagnosis, clinicians would also then be able to identify and list the problematic traits and the rates of severity of impairment that's caused by these traits in their day to day functioning. So, according to the proposal, the five groups of problematic traits would be eligible for a diagnosis of personality disorder trait specified if they have negative affect, detachment, antagonism, disinhibition, and psychoticism. While this is not part of the DSM 5 currently, in the future it may be. So, it builds off of the five traits to create their own trait specified version of personality disorders. I'd be interested in hearing what you think about this. I hope that this video was helpful. As always, if you have any questions, comments, or concerns, please feel free to reach out to me via email. Also, please don't forget that your extra credit question is due by this Sunday at 11:59 p.m. on Canvas. All you need to do is answer the question below, take a screenshot of your response, and upload it for 1 point added to your final grade. I hope that you have a great day, and remember to be well.